Good afternoon and welcome to this very interesting IC on breaking the deadliest of all formation of the complex cataract with innovative surgical technique. So most of the speakers are going to show their own innovation, how to tackle with the complicated cataract. So our first speaker is Dr. Shakya, and he is the renowned and a very fast-forward surgeon and well known from Chitrakoot, and he's going to talk on just a minute because we do not have the program sheet. I don't know because they've not given me.
So,
तुम्हारा टॉपिक क्या है बता
yes,
दीजिए.
sir, I will come.
हाँ तुम बता दो.
So, thank you, sir, for the kind of my information. And my topic is the way to deal with the challenging case of the uveitic cataract. So, as you all know, the complicated cataract second to the other systemic conditions, and it is required to different approach to management and different therapy to pre and post operative period, and additional manipulation and instrumentation during the surgery. So, in the cataract study, in the complicated cataract is one of the challenging with the greatest number of the unknown factor faced by the ophthalmologist. Technically, aspect the surgery itself due to the limited access to the due to the posterior synechiae, pupillary membrane, or pupillary synechial sclerosis, or some RSL delicacy, and vascular abnormality and pre-existing glaucoma is actually associated with the complicated cataract. So, and then the post-operative actually inflammation also very high. So, the indication, as you all know, so these are the factor the complicating the surgery at the, as I told previously. So all actually the investigation, routine examination should be done, and all test, all the laboratory test is done, and after that we should also counsel the patient the limited visual prognosis and recurrent and chronic nature of the disease, and prolonged follow-up, and increase the need of the medication in post-op period and need of the additional surgery. So the eye should be quiet for the 3 months, does not mean all of the medication. So or the steroid and antibiotic combination should be actually used. So I am actually showing the some cases. So how to deal with the this complicated cataract in so the as we see the first case, actually this is the associated with the slightly fibrin membrane, and initially I actually 1 month ago actually I used the steroid and antibiotic, so the eye actually become quiet, but there was a chamber is slightly shallow, and there was a membrane here. So by this reason actually I just remove the membrane with the help of the Atrata forceps first, and put the visco in between, and then both side, and then go very slowly, because sometimes the iris also pulled and conquer the dialysis, and then after that putting the some amount of the adrenaline. So we dilate the pupil properly, and then put the visco, dispersive visco. After that put the actually the high molecular weight viscoelastic, so the more dilatation of the pupil, and also behind the iris to push the iris properly. After that you make a rhexis just behind the iris. You can go very gently, so you can make a slightly larger rhexis, because the chances of the phimosis is very high. So after that we do the multiple hydrodissection. This case was very actually simple, because the cataract is very grade 2-3, and after that we remove with the help of stop and chop out technique or any technique. You can lift the cataract also in the antechamber and actually emulsify. So crack the nucleus into 2 parts. After that we emulsify the whole nucleus with minimal minimal parameters. Because in the complicated cataract actually endothelial count is also less, and during the removal of the cortex you have to slightly go very gently, because sometimes the iris actually pulled out in the aspiration port, and use the hydrophobic lens. So another case also very simple, and sometimes the pupil is slightly flexible after removing the membrane. So actually, I always decided to when to put the iris hook, when to put the rings. If the pupil is slightly flexible, you always put the rings. So this is the BX ring. So after putting these rings and the pupil is dilated properly, and then you can easily do the cataract surgery in this case, in this type of the cases, and emulsify the nucleus very easily. And this is the case was the post trabeculectomy and bleb was there. And then after putting the lens, you always put the some amount of visco under the iris and then remove the rings. Even the flexible is that people also distorted. This is case is very complicated, and this membrane was there. So in this type of the cases when the pupil is slightly ridged, so you always actually slowly break the synechia behind the iris and then pull out the some membranes, and with the help of the Vanna seizure you cut the membrane and then you can remove. But the even dilate the pupil is slightly ridged. So by this reason I put the 4 hooks, but not stretch more. Only the optimum amount of the actually iris is pulled. So the you can visual access is clear. So you can, if the you are all are the efficient surgeon, you can do the phacoemulsification very easily. So another case actually the cornea is also adhered to the iris. So there is no space. When I make the side port, the actually side port gone in the iris. So thereby it become a slightly PI. Then after putting the visco, the chamber become deep. And then after that I try to actually remove synechia actually broken, and then I use the retractor sometimes. So we cut the help of the retractor, slightly make the pupil slightly circular, and sometimes in this case actually the anti-capsule is touched. So by this region actually, and then membranes also comes out behind the iris, from the iris, behind the iris. So I remove it, and after that the cataract was very soft, and then you have seen the there the capsule also adhered to the margin. So and then cut it with the help of the Vanna seizure, and then make a slightly circular axis again. And after that, we just displace the iris with the help of the another aspiration irrigation cannula, and then put the lens in the bag. So as you all know, after that we can put the intravitreal injection if the indicated. So as you all know that the cataract so we conclude that the management of the uveitic cataract requires the careful case selection and prior and proper timing for the surgery and meticulous surgery and close monitoring, appropriate handling of the post-operative complication. These I have achieved the good visual outcome with the proper management. Thank you so much.
Thank you, Dr. Shakya, for the wonderful videos of post-uveitic and complicated cataract. Any question from the house?
Hi, in this video we discuss zeptocapsular.
Yes.
But Dr. Sakya, first of all, you made all this complicated surgery very easy. My question is, how long do you wait before the inflammation is controlled before you do?
So at least depending upon the actually anti-chamber inflammation. If the chamber is acute, you have to clear the anti-chamber first. Only the 0.5 cell is acceptable, but you at least do the 3 months. 3 months. Atropine, sir. Atropine, even I give the about 3 months up to 3 months, at least. Even sometimes when the uveitic person also deal with, I am not uveitic person, but they deal with the very good, because they are this condition associated with the many systemic diseases. So actually treat the diseases properly, and then sometimes because the inflammation is the on and off, So use the steroid and the atropine is in the made very long, actually even long. Thank you, sir.
Good.
Thank you
Thank
so
you,
much.
thank you, Dr. Shakir, and you can join us here. So our next speaker is Dr. Satanshu Mathur, and you all know him, most active person in most of the conferences, and must have seen him, and very good surgeon. So he's going to talk on innovative approach to posterior polar cataract with hard nucleus and strategies to prevent the posterior capsular rupture.
Good afternoon, everyone. Posterior polar cataract is always a threat for even a best cataract surgeon. Sound nahi hai. Sound band kar do. So, if we take some precautions or tips, we can have 100% success in every posterior polar cataract. Most important thing is the slit lamp examination, pre-operative. This valve-like appearance made it different from the posterior subcapsular cataract. So you have to very carefully examine, and you can examine on the OCT also to see if there is a P defect or not. This appearance always keep in mind and examine carefully where is doubt on the slit lamp. And that will give you because in 33% cases of posterior polar cataract, there is a posterior capsule deficiency. So we have to be very careful while operating posterior polar cataract. We should see slit lamp, there is a posterior deficiency, posterior polar defect or not. So this simple things are simple, same way we have to approach. This is valve-like appearance. You have to inject a dye because you have to see the margin of the capsule very carefully, even if the cataract is not very hard. All the procedures are same till now. Now comes important question, capsular axis. So Dr. Karamjit has advised or advocating the oval capsular axis that is very helpful in removing the nucleus and the cortex at the 12 o'clock position. So oval capsular axis is very important. We should do the capsular axis adequate size, because if there is a posterior capsule defect, we can put the lens in the sulcus over the capsule. So we have to not make very big but adequate size and oval shape. This is a thing. When we should avoid hydrodissection. Whenever we inject fluid inside, the fluid goes behind the cataract, behind the posterior capsule cataract, and that causes the posterior capsule defect. This is a cannula which has not the opening on the front but opening on the sides. So when we inject the fluid, it goes not behind the capsule lens, but it goes in the behind the lens, not on the behind the posterior capsule. Yes, this way. So there is chances of in the previous. I will show you. So here, when we injected the fluid, it is going behind the capsule. You see, it is behind the. Yes, here the line. So when we are doing with the cannula, this is not going behind. When we are doing this cannula, which has not tip on the front but on the sides, the fluid not go behind the posterior subcapsular cataract, it goes above it. It separates the nucleus with the cortex. So our purpose is solved. Even if we do hydrodissection, it will not cause any problem. But otherwise, we should avoid the hydrodissection, because this is the hydrodelineation tip 4. Before doing hydrodelineation, we are making a crater or sculpting the nucleus very gently as scattered. And when we are doing hydrodelineation, we are doing in the margins, under the margin of this crater we have found. The hydrodelineation done under the margin of this crater, not blindly in the nucleus. So fluid will never go behind. So this side, and then again behind this edge of the crater, we have this side. So fluid will go inside and we will get a very good ring here. This is a very good ring. You can see the ring here. We can get a very good ring. Hydrodelineation fluid is no chance to going behind. So these tips are always very helpful. Now when we are doing the things, every parameter should be very low. Botal height, phaco power very less, because we don't need phaco power. Vacuum is less. And we are trying to uplift the nucleus. You see, from side we are uplifting the nucleus away from the posterior capsule before taking it out. We are trying to stay away from the posterior capsule. So The tip is AC should be maintained. So whenever you're removing the instrument, you should always inject viscoelastic inside the eye. That will make your chamber stable and not will increase the PC if it is there. So now comes the hydrodissection. Bimanual in such cases is very good because it's a very slow process. And we are not removing the cortical matter from behind the capsule. We are trying to pull it inside into the center, and then we are doing the aspiration. Hold, bring it into chamber, and is in the center, and then pull. Again, inject viscoelastic before removing the instrument, pulling it in the center, and then aspirating it. Holding, pulling, and then aspirating. So in this way, you can have very high success rate in cases of posterior polar cataract. Now you can inject the lens, and there is no difficulty. You can center. This is I will push behind further. So this is so you can have an IOL inside the eye in the back. There is no issue. But now come to the second case. So tips is correct preoperative diagnosis. Okay. Correct preoperative diagnosis. Small but adequate axis. Oval shape. No hydrodissection. Gentle hydrodilation. No nucleus rotation because we increase the PC rent. AC maintained. Low parameters and slow motion phaco. And when you do all these things, you may achieve a high success rate. Now this is another case where the pre-existing defect in the posterior capsule. So we have to be more careful because there is a pre-existing defect. We have to be more careful. All the parameters the same which we are following. Gentle hydrodilation, your ring should be formed. So you can know there is a hydrodilation is complete. Do not rotate the nucleus. Try to do maximum chopping from the same point, holding at one point and to the chopping at different point. Gentle maneuvers, because large PC rent we have already seen on the slit lamp, that a large PC rent behind the. So we are fast forwarding it. So you should have a patience in such cases because you do not have cases daily in the OT. You have once in a while such cases. You should have given double time than the normal time in all these cases. हाँ light की problem है. And you see, we are removing this shell, this epinucleus, this in the last because it is protecting the posterior capsule. Then inject visco from the side port before removing the instrument because already posterior capsule deficient, it should not increase. Then for the aspiration cortex does from the side ports, same thing. What I want to show, all the procedures are very slow. You see, this point I want to show you. There is a preoperative central, in the center there is a preoperative posterior capsule defect. And this defect remains same even after the surgery because we have taken all the precaution. So this defect remains same, this does not increase. So this is the beauty, if you follow the simple rules, the defect will never increase, it will remain the same, which is preoperative defect. You can see the defect, I think everybody can see the defect there. So just follow simple tips and you can have a success rate without making this. So we have put a posterior in the back lens in this case also because there was no visual disturbance. Thank you.
Thank you, Dr. Satanshu, for the wonderful presentation. And in posterior polar cataract, one of the most complex cataract to deal with, the two important things what he has said is, first and important thing, never do cortical cleaving hydrodissection. That is very important because if you do the cortical cleaving hydrodissection, your posterior capsule may burst out and the nucleus may drop. That is one thing. And second thing, in a pre-existing posterior capsular defect, if you have a that can be detected nowadays with the help of the OCT. And even a very good slit lamp examination, you can detect if there is a defect in the posterior capsule or no. If you have a PC defect, then the aim has to be like if you are your whole surgical process should be like if you are dealing with a PCR case. So you have to do the steps so that your disrupted posterior capsule should not extend further and you complete the surgery. So any question from the house? Thank you very much.
And like to invite next speaker, Dr. Rajendra Prasad, and he is the renowned phacosurgeon, troubleshooting failed chop with innovative surgical techniques. So when you are in trouble, so Dr. Prashad is there to help you. Dr. Prashad.
Thank you very much, Dr. Alkesh, for inviting me here to talk on this particular topic. So I'm going to talk on the failed chop, troubleshooting the failed chop. Yeah, okay. So you know that the chopping techniques actually it utilizes purely manual mechanical instrument forces to fracture the nucleus. So we are using the chopper and we are using the help of the phacoprobe. So these are the two instruments which helps us to fracture the nucleus. And nucleofractus would depend on the geometry of the vector forces you used during the fracture of the nucleus. If you tend to have a failure in the fracture of the nucleus, if you don't get the fracture of the nucleus, it means there is a misaligned vector forces. So the vector forces, how it could be misaligned, like either you are very superficial, your penetration of the phacoprobe is very superficial, or it is asymmetrical manipulation of the phacoprobe as well as the chopper, or there could be a misalignment of these two instruments, or if you're lifting it, you're too much lifting it, then also you may not get the fracture. So I can see here in this video, because I'm trying to fracture, but I'm not getting the full fracture. You see the nucleus, I'm trying to separate it, but the nucleus is still intact. So there is no fracture has happened on the nucleus. It's just the peripheral fracture which is happening. And if you have it, if you don't get the complete fracture of the nucleus, then you have these conjoined segments. And if you have a conjoined, this is the common problem we come across in a very hard cataract. You are left with these conjoined segments, and you just try to pull them out with the phacoprobe. And a lot of manipulation would require to draw these pieces of the nucleus for the emulsification. And the problem which could happen the many of time, like you tend to have the complication in these cases, and the complications could be in the form of high CDE value, like if you may increase your phaco energy to emulsify these conjoined segment, and you may have endothelial damage and thermal injury. So these are the complications we may come across. Or if you are pulling and pushing it too much, you may have a shear rupture forces, and which could lead to the PCR, jonular dehiscence, and nucleus drop also in these cases. So what to do then? If the vector forces fail, then what you have to do, either you have to change your chopping technique, or you have to change the direction of the vector forces, like you may change from vertical to horizontal, from horizontal to terminal, or stop and chop, or the technique which is more comfortable for you. And if you are changing the direction of the vector forces, then you'll have to change the chopper also. See, these sharp chopper or thin chopper, flat choppers, you'll have to change the chopper if you are not getting the fracture. And if you are changing the chopper, then you have to change your phaco settings also. You have to increase or decrease the vacuum. You have to increase or decrease the irrigation and aspiration mode. So all these things would happen. And the changing the chopper, like you have various types of the chopper. So what I would suggest, this is one of the very specialized chopper, which is very efficient to generate tensile fracture force, because you need a tensile fracture force to crack these hard nuclei. And this is a special kind of chopper. You can see it's a wedge kind of chopper. The tip, you see the tip is ball shaped, it's round. The inner edge has a wedge. It's a triangular wedge, what you can see here. And if you use, now you can see the effect of this chopper, like you just hold the nucleus, go around and hook it, and you have to just bring it in, and you get a complete fracture of the nucleus. So this is the kind of fracture you require actually in these hard cataract, and this would happen only if your vector forces are correct. And to have a correct vector forces, your instrument have to be correct. Now you can see another case of very hard cataract. You just hold the nucleus, go around, hook it completely. You have to hook the nucleus completely. You hook the nucleus, draw it inside, and you get a complete fracture. Now if you are getting a complete full thickness fracture, your fragments become free, and these free fragments, then it's very easy to draw them on the phaco probe and emulsify with a minimal amount of the manipulation and minimal amount of the phaco energy to be used in these cases. To start with, your preoperative examination has to be correct. So you should know that what kind of cataract you are dealing with. Your pupillary dilatation is very important. Never attempt the phacoemulsification if your pupil is small, especially in these hard cataract. You can use the pupil dilator, you can use hooks, rings. Your capsular axis has to be good size, like it should be at least 5.5 millimeter minimum. Don't attempt these hard cataract if your capsular axis is 4 millimeter or so. Large nucleus, and then you must make sure like you have rotated the nucleus. The nucleus is free within the capsular bag. Use your chopper, which is more comfortable. I'm using here the same chopper. This is the wedge chopper. And your phaco probe, you see the tip should be exposed a little more than the normally, because it should be at least 2 millimeter tip should be exposed. And hold the nucleus firmly. Your vacuum should be good, a high vacuum, and hold the nucleus properly, and then you see the fracture. Now, if you are using this technique, then you can see you get a complete fracture of the nucleus. The nucleus is now in 2 segments. So total fracture, you are not left with the posterior plate even here. Such an hard nucleus, and you see the fracture, the kind of fracture you get, and these pieces are now absolutely free. You draw them easily and start emulsification. You can see another case. This is very hard cataract, again grade 5 or 6, almost very hard nucleus, brown, dark brown nucleus. Now see the fracturing this nucleus. Hold the nucleus properly, impale it well into the nucleus. The tip has to go inside. Hold it and bring it slightly, draw it, hook it, and then get the fracture. Now this fracture is very important in these hard cataract. If you don't get the fracture of the nucleus, the whole surgery will become very difficult to complete, because these conjoined segments, and drawing these conjoined segments later on during the emulsification process would be very, very difficult. Now you see, because this is how you get a complete fracture of these nuclei. And many times if you have these leathery brown nucleus, then you have to do a lateral separation force also you have to use many times to separate the nuclear fragments completely, because if you have a complete nuclear fragmentation, then hold these fragments softly and start emulsification. So another case, so this is another very hard cataract. The grades are increasing slowly, and this is around again grade 5, 6 nucleus, and this is the kind of fracture you get. So your vector forces, your manipulation, position of your chopper, and the type of the chopper, so all these things would matter if you are dealing with these very, very hard cataract. And if you get a complete fracture of these nuclei, then the surgical result would be perfectly all right. Now this is the grade 6, even more than grade 6. Again, I'm using the same technique here. Hold the nucleus, and you see the fracture of the nucleus. This is how you get a complete full thickness fracture of even this kind of, otherwise we would have gone for the ECG or small incision cataract surgery in these cases. But if you are getting a fracture, then there is no problem. Like you can continue with the phacoemulsification, even this kind of cataract. Then, because if you have 3 segments, the emulsification becomes very easy, because then you use the energy after holding the nuclear pieces. You don't have to use the energy before and after that. Just hold these segments and use now you see the kind of the fracture you got, because as if you have cut with the knife. So this is the kind of fracture you'll get with this technique, and see the sharpness of the fracture. Then the next heminuclei, you just hold this nuclei again with the phaco probe. You see the position of the phaco probe, hold it, go around and fracture the nucleus. And then you complete the emulsification, and you see this kind of grade of nucleus. and then implant your IOL, and and the, the patient would have a crisp vision on the next day itself, even in this kind of cataract. This is a free nucleus, and absolutely free nucleus. This was a Morgagnonian cataract, a freely mobile nucleus, but very hard nucleus. Again here, like otherwise normally the other choppers may not work here very well, but here you can see, because I'm just holding it, and look at the vector. Position of the chopper and the position of the phaco probe is very important, because it has to be parallel. It should not be radial or something, like it should be parallel, and it should be radial to the curvature of the nucleus. So that is very important. If your position of the phaco probe and position of the chopper is correct, then only you'll get this kind of fracture. So this is the position. I'll just show you. This is the diagrammatic presentation. This is the position of the phaco probe, how you have to put in, and you are slightly drawing the nucleus and seeing the edge of the nucleus. Once you see the edge, then hook it completely around the nucleus, and then draw it, and you get a complete fracture. So to conclude, in rock hard cataract, if you don't get the fracture, the surgical technique and technology should aim to generate least energy, especially in these hard cuts. You do not generate too much of energy, because otherwise you'll get a wound burn and the corneal endothelial damage. Minimal manipulation, minimal strain on the zonules, because zonules, you have to take care of the zonules in these cases while protecting the corneal endothelium and the capsular bag. Thank you very much.
Thank you, Dr. Ayender. Because this actually the hardest cataract he has shown is cannot be done by the simple chopper. You have to have a very sharp chopper or long edge chopper you have to use. But this chopper he is using, it's an advantage that at the tip there is a blunt area, so chances of posterior capsule damage are very less. But definitely, when there is a hard cataract, there is less space in the periphery. So how you will suggest you have to pull the lens? That's okay. You have to pull the lens to find out some space at the equator to hold the.
See, generally, because very hard cataract, it's a shrunk nucleus. So you don't, because it's the very bulky nucleus, you'll not find too much of bulky, because it's a shrunk nucleus, very hard shrunk nucleus. You would find a good space to hook it. But if you are not getting a good space to hook it, then what the idea is, then what you need to do is just hold the nucleus, tilt it slightly. You have to tilt it slightly to see the edge. You tilt it, because the capsular bag is very big in these cases. So you just tilt it and then hook it, and then go back into the capsular bag after hooking, and then crack it. So that can be done in these cases.
Thank you, thank you. Thank you. Now we invite Dr. Alkesh. He is another prolific surgeon from Delhi.
So Dr. Alkesh is a vitreoretinal surgeon, and he's also a very eminent cataract surgeon also. So he is going to talk on IOL placement in subluxation, subluxated cases.
Good afternoon. I am really grateful for giving me this privilege to do my presentation. I'll be presenting different cases of IOL subluxation. Extreme decentration, that IOL optics covers only small fraction of pupillary area, and causing problem in the visual rehabilitation. Luxation, total dislocation into posterior segment is uncommon complication of cataract surgery, yak capsulotomy, multiple problems. So when we need to intervention and manage those lenses, so incidence is around 25%. Clinical significant decentration, 3% cases with clinical significant decentration, 0.2 to 1.8 cases posterior segment dislocation. Factors different responsible, preoperative, peroperative, postoperative. I'm not going to details, showing my videos, accompanying complication, inflammation, IOP, increase, corneal decompensation, then retinal damage, symptoms, unwanted optical. Main is the visual rehabilitation. So examination, we have to see the corneal status, integrity of anterior and posterior capsule, anterior chamber, IOP, indirect ophthalmoscopy. If we can do, we see the periphery of the retina, any with heme, CME, vitritis. So management concept is back to front approach is the best for these cases. Now this is a post-traumatic patient had a trauma and lens got dislocated. The lens is still lying in the anterior chamber. You see made a side port. just with the help of a small chopper, lens hook, you can place the lens and place in the sulcus easily managed. So it has to be managed, otherwise causes distortion, astigmatism, and now this case you see partially dislocated, but still in the anterior chamber I made a side port through sclerotomy 4 millimeter away from the sclera with the vitreous cutter. We did the vitrectomy, anterior vitrectomy, and you see the lens is trapped with the partially with the capsular bag, and so we planning to try to replace again with the side port simultaneously without any opening from inside, and we are trying to place the lens in the bag. And see the only vitreous stands being removed. Vitrectomy has been already any adhesions, so vitrectomy has been already done from the side port. And if you see the lens is well centered now in the, and further vitrectomy any anteriorly anything struck, so swapping with the depositor we see any round pupil well centered IOL. Another case, this was post YAG. If you see YAG capsulotomy was done, it was quite big. So lens is falling behind. So again, but in the anterior chamber, same route we are managing now with the, again the side port, doing vitrectomy. Then made a scleral tunnel just to tuck one haptic in the scleral tunnel, scleral fixation of one haptic, raid roll technique, one below the haptic, one loop going below the haptic, one above the haptic, and finally we replacing here. Once we replace, we still saw that other end is also hanging. So other end. So from again, we go with the railroad technique. Again, with the 9-0 proline suture, we are tucking the other haptic also in the scleral tunnel. You see nicely tucked both the haptics, and now the IOL is well centered. And we made a port from one side, and we did vitrectomy, whatever the vitreous were there, Nina to go behind and nicely doing the major surgery of VR and managing so easily. Now another case, per-operative multifocal IOL subluxation, if you see. So IOL is but still hanging. Again, going from the behind, because there was some cortical matter behind, so we have to go for 3 port, again placing with the help of a cutter itself. Then the side port, removing and placing in the, without removing the IOL, we're just trying to replace these IOLs inside only without making any opening. Again, releasing all the synecdoche and making it central. Then going behind, vitreous and removing the whatever the cortical matter left behind. So absolutely clear, IOL well centered, pupil round, so well managed. Now another case of zonular dialysis. You see zonular dialysis lens is again falling behind. Similarly, we made with the made a sclerotomy tunnel, raid roll technique, again tying one, fixing one end at the scleral level, scleral fixation of one end with the 9-0 proline. And we could place the lens well in centered and see nicely placed and well managed. Another IOL, this was a post-trauma, posterior dislocation of IOL in the back with CTRing, total IOL fallen behind in the vitreous cavity. I am placing the sutures before I go inside, so that later on placing these sutures will be difficult. So it was managed in the periphery. So we are doing now, going behind, planning to do the sclerotomy. If you see, the bag is IOL in the bag with CTR ring. So already zonules were not very good. So there was a weakened zonule. So we are now managing further. You see, we are doing vitrectomy, removing all the vitreous around, whatever we could manage. And because it was very slippery, we tried to do the cutting, and I didn't want to cut the back because CTR ring both will come out and become complicated. Just bent the needle 24 gauge and introducing the needle in the cleavage between the capsule and the IOL optics. See, after just lift it up with that needle, just 24 gauge needle, slightly bent, lifting the lens up, bringing into the anterior chamber, made the opening, and because it was so slippery, I have to use the corneal forceps. So see, the lens is out, but CTR ring is still there. Lens is out, and that bag, if I would have cut it, so whole thing will be this. Now bag is with the CTR ring. So whole of the complex has come out, and now I am fixing the IOL in the sulcus. So 90 proline. So IOL has been placed in the sulcus, fixing along the mattress suture along the scleral flap so that that knot doesn't slip away. So finally, IOL is well placed, well centered. This is opaque IOL. Earlier we had a series of opaque IOL with folded aptics. So how to manage this? So this not easy because the folded aptic, it come out of the bag very easily. Just bring it out, take it out from the opening and place with the another lens in the bag only. Another case is a post PK, now taking out the again the
Alkesh,
subluxated
wind up.
lens.
No, wind up.
Subluxated lens, again the same red roll technique, we just fixing the haptic on the scleral and doing vitrectomy whatever there was a vitreous loss and managing this. Final case, this is secondary retroiris IOL. So this is a retroiris, removing the lens and fixing this retroiris. So easy to place this retroiris lens. This retroiris lens going behind the iris and just tucking the iris in the haptics of this retroiris. You see the IOL well placed in the posterior chamber. So there are different options like that to manage. So post-operative care we have to take, and prognosis is excellent. Visual result with a low rate of complication if proper technique with vitreous management are followed. Late prognosis depends on the prevention of cornea decompensation, RD, choroidal hemorrhage secondary to surgical manipulation. Don't run after dipping IOL. Don't try another IOL without removing the previous IOL. Do apply extra suture to secure wound to avoid leakage, port and hypotony. Refer to retina specialist without any delay once lens is fallen back. Timely right way intervention will give the best results. Thank you so much. Thank you.
Thank you very much. Thank you, Dr. Alkesh, for showing such complicated cases being managed so simply. Thank you very much. So now we have a next speaker, none other than Professor Arvind Maurya. And you all know him. He's a great surgeon, great speaker, and a great friend. So he's going to talk on perioperative and intraoperative antibiotic prophylaxis in intraocular surgery.
Thank you so very much, sir. A very warm good afternoon, esteemed chairpersons and my dear friends. So my talk is how to prevent the dreaded complication, that is endophthalmitis and the infections in the intraocular surgeries. So for the prophylaxis, we need antiseptic cleaning of the periocular area and antiseptic solution on the ocular surface for the minimum contact period of 3 minutes, and topical antibiotics pre and post-op as well as intracameral antibiotic prophylaxis is very much in vogue now. So this povidone iodine is a water-soluble complex formed by the combination of iodine and polyvalent pyrrolidine, and it exerts bactericidal, fungicidal as well as virucidal action. And in case of poor PI tolerance, we can use the low concentration of the povidone iodine or chlorhexidine 0.05%, we can use that. And for the periocular skin scrub, 10% applied to skin of eyelid and forehead of the operative eye just before surgery, And in vivo studies on the ocular surface, it shows a 96.7% kill rate within 60 seconds, and draping to isolate the lashes as well as the lid margin. So now coming to the different evidences like the RCTs or the systematic meta-analysis. So this preoperative povidone iodine in the conjunctival sac is important for the clinical outcome, and 5% povidone iodine drop 3 minutes before surgery, and it decreases the conjunctival flora growth to 91%, and there is no bacterial resistance till now. And you can see the 5% has the more the plot of the post irrigation against the pre irrigation, the colony forming unit on a logarithmic scale. So 5% was better. It was an RCT double blind as compared to the 1% iodine. The antibiotic are the fluoroquinolone, the aminoglycoside, cephalo, and the chloramphenicol. Route of administration, topical, intraocular, subconjunctival, and oral. Timing is pre, intraoperative as well as post-operative. And duration and frequency, 1 day, 3 days, 1 week, and 2 week. And now coming to the intracameral antibiotics, so AC get contaminated during surgery in 5 to 43% in routine IOL cases, and also because of the surface fluid influx into the anterior chamber causing inoculation during surgery. And these are cefazolin, cefuroxime, vancomycin, but moxifloxacin is integral part of most of the cataract surgeons. And now coming to the safety and efficacy of intracameral moxifloxacin for prevention of post-cataract endophthalmitis, again an RCT with very good sample size. So significant p-value difference as compared to the normal endophthalmitis rate after giving the intracameral. So it comes as Oromox also, so 0.1 ml injected in AC at the end of the surgery, and we can use the preservative-free Vigamox also. I have no financial interest. So dose is 0.5 milligram per 0.1 ml, and this is how we can make it. And again, efficacy of intracameral moxifloxacin, and this was the world's highest sample size study. It shows that in the SICS, there was a 4-fold reduction in the post-operative endophthalmitis rate, and 6 times reduction in phaco. So now coming to the meta-analysis, which are the highest order of evidences in the academic field. So again, all these prove that this post-cataract surgery, moxifloxacin works very well. I hope you have watched the disinfection sterilization AIOC adverse event committee, this first module, and now the second module is still going on. You can watch on YouTube and even after logging on. So it has more than 11,500 views now, and thanks to the AIOC big guns for giving me the opportunity. I am the program director, and this booklet PDF we have already circulated, mailed to every AIOC member, and the physical copy also all the AIOC member will very soon get after AIOC. Thank you so very much. My acknowledgement. Thank you, and do visit Khamma Ghani, Padharo Mare Des. Do visit the lovely places and enjoy the cuisine. Thank you so very much.
Thank you very much, Dr. Arvind, for the wonderful presentation on antibiotic uses and prevention of the endophthalmitis in these complicated cases, especially because it works. I hope everyone is using now the intracameral antibiotics.
How many using intracameral now? Yeah. Almost everyone now.
Almost. Yeah. So it has become a new normal now, because to use the intracameral antibiotics and for the prevention, because since we started using the injections, I haven't got any endophthalmitis now, I think almost 10 years now. And otherwise, earlier we used to get, and even after taking all the precautions, we used to get at least one case in a 2 to 3 years. But now, at least for the 10 to 15 years, we haven't got any infection after we have started. I think this should be your same experience.
Yes, same. I agree with you.
Dr. Mathur, you want to say something?
Now we are definitely using in each and every case the moxifloxacin, and definitely what you are saying, because normally we also do not have much infection care, because protocol is very strict at our hospital, and if we follow the proper protocol, proper selection, otherwise also chances of infection are very less nowadays. But this moxifloxacin has definitely given an advantage over the previous.
Thank you. Thank you very much. And now we have the great speaker, Dr. Sudhank Bharti. You all know him. He's one of the most energetic and surgeon, even the proficient surgeon, and energetic surgeon even at this age. And the youngest eye surgeon, yeah, that's true. So he's going to talk on management of the subluxated cataract.
Thank you, Dr. Rajan Prasad, for giving me this opportunity to talk on this management of subluxated cataract. It's a very, sometimes when you have these subluxated cataracts, you have kind of lot of things coming in your mind as to how to manage and what happens if there is something which is happening intraoperatively and then your हिंदी में हाथ पैर फूल जाते हैं और फिर जो है then you come back and think what to do and how to manage and on top of everything else the patient doesn't recognize. They don't realize how much micro infarcts you have gone through while doing this kind of surgery. So anyway, this could be a congenital. So there are many causes of congenital. Many of us have seen all of them. Some of us have seen some of them, but once in lifetime you will see one of them definitely. And it could be mild, like lens edge visible in 25%, moderate 50%, and severe more than 50% of the dilated pupil if the edge of the lens is visible. It is best to examine a patient with severely subluxated lens in both upright and supine positions, and that will give you an idea as to what will be your modus operandi or approach during the surgery, because if the lens is moving, then your approach will be different. Degree of zonular loss may be localized, and extensive generalized weakness like in PXF is very important to realize that you will be having something during the surgery also. And a round lens edge indicates total loss of zonules. Sometimes you have that, and then probably it's more difficult situation. Already complex situation is more complex in the presence of a hard cataract, rigid pupil, coloboma, vitreous in the anterior chamber, anterior subluxation and very deep AC as in myopia, and then you have to be very, very, So surgical planning is definitely the anesthesia, and sometimes you need to give mannitol because you want to have a kind of very controlled IOP at that point in time. Up to 25% zonulopathy, slow and careful phaco, plus a little bit of help with the capsular hooks. In progressive pathology like PXF, a CTR is a must. And in a young patient, back fixation to sclera, primarily because all these pathologies increase with the age, and you will find subluxated iris IOL back complex at a later point in time, maybe after 15-20 years, when the patient is having a compromised health also on top of this issue. The incision should be away from zonulopathy, and all these side ports should be more corneal. So this is very important, like in all those cases of RK, out of the context this point is, but in all those cases you want to do a scleral incision. In cases of incisional keratotomies, here you want to do more corneal, and tricot assisted vitrectomy and trypan blue painting under visco to avoid entry of trypan blue into the vitreous. So that is very, very important, because trypan blue entering into the vitreous reduces the red reflex and visibility. And microcapsulorhexis forceps, which can be used through the side port, and also eccentric rhexis if there is a lens is eccentric. Back fixation could be because of the with the CTR, or segment
capsular tension segment or Sioni segment sutured to the sclera and along with capsular and iris hooks. Points to remember is ectopia lentis signifies a displacement or malposition of the crystalline lens, and pseudo-exfoliation syndrome is probably the most common cause of adult onset zonular dehiscence. And in patients with subluxated lenses, a comprehensive ophthalmic examination should assess the posterior segment as well. And phacoemulsification technique used in ectopia lenses depends on the degree of zonulopathy and its underlying pathophysiological. So this is a small video, and this is this.
Intraoperative zonular dehiscence can lead to IOL bag complex dislocation, cystoid macular edema due to bag donesis, secondary glaucoma, and corneal decompensation. This eye is on long-term anti-glaucoma therapy, has peripheral iridotomy, a meotic non-dilating pupil, and phacodonesis. A toric IOL implantation is planned and axis is marked. After making the ports, the viscoelastic is injected and Maillard ring is used to dilate the pupil to 6 mm.
It is very important to keep one ring of the Maillard ring just below the main port so that your iris never comes in front and touches the phacoprobe.
The Maillard ring is then centered. A Zepto handpiece is then inserted to achieve a central 5 mm capsulotomy. This does not cause any stress on the zonules and a perfect capsular axis is achieved very easily. The Zepto handpiece is then taken out. Hydrodissection is done to make the shaded quadrants are emulsified. A capsular tension ring is inserted. The maneuver is stopped and gently the phaco tip is taken out and viscoelastic is injected to inflate the bag and to get the equator of the bag in its physiological place. A capsular tension ring is inserted. Presuming that the CTR will stabilize the bag. Using the zonules on the other side. But the bag is still mobile as the edge of the capsular tension ring is visible. So a small port is made and a hook is inserted to hold the capsulotomy edge, thereby stabilizing the bag. Nucleus management is then proceeded but due to some still movement of the bag, another hook is inserted to stabilize the bag more firmly. And then nucleus is managed successfully. Through the side port, a needle is passed through the sclera in the sulcus after creation of a conjunctival flap. The other end of the suture is passed through an eyelet of the Sioni segment, and this segment is gently placed in the bag, and the suture on the sclera is tightened to stabilize the bag. Tightening of the suture pulls the bag into its physiological position and stabilizes the bag perfectly. The hooks are now removed.
After that, it was not very difficult to implant the lens. Thank you very much. Thanks, Dr. Arti.
Thank you very much for showing this wonderful and very complicated case. Now our next speaker is Dr. Suresh Pandey, and he is going to talk on challenging cataract for premium IOL management with Zepto and nanopulse technology.
Thank you very much, Dr. Aryan Prasad sir, for inviting me to participate in this wonderful instruction course. Dr. Bharti already shown very nice case of challenging case of subluxated cataract with Zepto with the malignant ring. So many pearl of wisdom. As we all know that the capsular axis is the most important step of the cataract surgery for especially with the premium lens implantation. So there are many methods of doing capsular axis by Utrata cystotome, by 26 gauge cystotome, Utrata capsular axis forceps, microincision rexis forceps, or combination of the forceps and the needle technology. So in India, white cataract, white intumescent cataract is not uncommon because of the long-rooted belief that मोतियाबिंद को पकने के बाद ही कराना चाहिए. So in such cases, you have seen that the rexis may go erratic. They can be small rexis, and because of the associated capsular fibrosis and because of the high intralentricular pressure, there can be Argentinian plague sign. So in such cases, it's very important to note that we cannot implant the premium lens, especially toric or trifocal toric lenses, in cases of runaway rexis or in cases of compromised capsule zonular integrity. In some cases like white mature cases, they can be fibrotic capsule, and now we have tools and technology to manage the capsule successfully, which includes Zepto nanopulse technology, which include the femto laser technique, which is one of the most exciting development in latest in recent time. The femto carries many advantages, but it's expensive, and secondly, there is a disposable cost, and also it impedes the workflow. And capsular laser is another recent technique which can be helpful to provide the capsulotomy, and this is the capsular laser capsulotomy, and you can see the studies done with this laser. The stretching studies, it confirm that the capsule margin is well maintained and well integrated, and the capsule laser is not available in India right now, so I would like to share my experience with the Zepto nanopulse technology. And this is the first case, 5-month-old child who came to us from Mumbai, and I have done the cataract surgery of her father also. So she's a 5-month-old child, and we have used Zepto nanopulse technology to do the rexis. As we know that in pediatric cases, creating capsular rexis is a little difficult because of the highly elastic anterior lens capsule, and the Zepto also have some limitation that you have to insert the silicone cup inside the anterior chamber. So in cases like pediatric eye or shallow anterior chamber, you have to be careful doing this technique. We used chondroitin sulfate viscoelastic to coat the endothelium, and the anterior chamber depth was normal. In this case, there was, this was not a microthalamic eye, and you can see with the Zepto nanopulse technology, the capsular rexis was done precisely 5.2 millimeter in size, and then the remaining part of cataract management is not difficult, and we have done the bimanual irrigation aspiration, and this was followed by implantation of the lens. And since this was 5-month-old child, so we did a primary posterior capsulectomy with anti-vitrectomy to provide the long-term clear visual axis. So this was the first case, and the second case I wanted to show you is 36-year-old a lawyer, and he came to us with the hypermature intermittent cataract, and you can see that there was a cataract was hypermature, and there was a milky fluid. So we planned this case for the Tridif lens, and this is the Zepto handpiece with the nitronol ring and silicone cup, and once you retract the device, then you can insert this device through 2.2 millimeter incision, and you can see within 5 milliseconds this can provide this can create very good capsular rexis because of the exposure evaporation of the water molecules between the nitronol ring and anterior capsule, and this is a capsular rexis done successfully. And once capsular rexis is done successfully, then you can implant the premium lens as we did in this case. This was another case of Zepto capsular rexis, and you can see the Zepto or rexis is done in case of hypermature cataract, and there is milky fluid. You can see the entire view is obscured because of milky fluid, but the rexis is done successfully, and in this case we have implanted the toric multifocal lens, and this is the last case I wanted to show you. This is the case where we use the phenocaine to dilate the pupil. This was phenocaine intracameral injection to dilate the pupil, and then we use Zepto nanopulse device to create the capsular rexis. And last case, I wanted to show you the case of the small pupil. In cases of small pupil also, you can do the Zepto nanopulse technology. And this technique is very important especially in cases where you want to implant the premium lens, and if the case is hypermature or mature intumescent, then you can ensure that the capsular rexis is done very, very well. And it's very important because to achieve the effective lens position. Thank you so much for your kind attention.
Thank you very much. Thank you very much. And finishing within a time. Thank you very much. And shown so many videos and very nicely, and very well done Zepto capsular rexis. Thank you, Dr. Pandey. And without taking much time, we close the session here. And I thank all my speakers and the audience, especially being here with us. And we'll have a group photograph now. Yeah. Thank you.